Everyone, we will go ahead and get started. Welcome to the May Action Period call. Agenda, we will do our normal report out for those that are on today. I know there's a few people that are on vacation or have other obligations. We'll do a data overview, and then Dr. W will be speaking again on developmental screening, which is great. Just a few reminders, please submit your next PDSA worksheet. Please schedule a coaching call if you haven't already. Dr. Bowling and I have been having coaching calls with a lot of practices and learning a lot of great information. So if you haven't been able to schedule that yet, please send me an email. And then if you have missed any action period calls or you'd like to go back and refer to them, the recordings have been sent to you in a folder. So for practices, I don't think Dr. Kumar's on yet, and neither is Dr. Obedo. Dr. Schwartz, I see that you're on. Would you like to give an update with how things are going with your practice? He's muted. He might not. That's okay. We'll go to Dr. Vargo.
Hi, it's Sue Vargo.
Hi.
Hi. So I think we're doing a little better in our data collection. Definitely identifying a lot more kids that need to be referred for the oral health and finding places to send them that will take their insurance. We're doing the developmental screen at 30 months, the ASQ. And interestingly, I think on that, we're getting more feedback that a lot of those kids have already been referred by that age. So we're not picking up a lot of new kids that need referred, thankfully, because we screen at 9 months and 18 months as well.
Great.
So, yep. But otherwise, things are going well. Thank you.
Great. Thank you for sharing. Dr. Call, I think I accidentally left you off of here, but would you like to share?
That's okay. So as I mentioned before, I have kind of like a revolving door with the RNs and the MAs that are there. So I like last week started implementing like a little huddle between the three of us so that we don't, so that we're all on the same page and that all the ASQs and the oral health screens are out and which age group to do. So we kind of do a brief little huddle there. So last week was pretty good. I think we got pretty much everyone. So that was good. And then I did figure out, I did go back and just like count since I'm just in the office.
I'm sorry.
No, that's okay. It took me less time to do that than the actual figuring out
how to
dicer. So I was done within 10 minutes. That was super easy to do. So I think the huddles will help kind of get everybody in on the same page to get the screenings in.
Great, thank you. Dr. Comer.
Hi, I know we talked in our coaching call not too long ago. But yeah, we're just working through implementation with a big residency practice and creating note templates. We're doing the suicide depression screening and the developmental screen. And so just implementing that across a group of people is a fun adventure.
Especially when they're family physicians and you're kind of working towards that too. So that's great.
Yes.
Dr. Bowling and I are going to speak with Dr. Comer's residents in a few months. If anyone else would like us to do this, and by us, I mean Dr. Bowling will do the majority of the speaking, we're welcome. We're happy to come and speak to your office or anyone that would like to more information, doing an in-person coaching call, going through the office flow, that kind of thing. Great, thank you, Dr. Comer. I think that's all we have for practices right now. I'm sure they'll trickle in. I got a few emails saying people are running late, and that's okay. Just to give a brief overview, As far as all screens, we went a little down from month 2 to month 4, but we're still close to 90%, which is great. I also broke up each of the different tools that people chose into separate screening areas. Oral health is up to 100%. The majority of you all, except for one practice, is doing oral health, so that's wonderful. Developmental screens went down a little bit in month 3, and I think that there was just some changes in practice, but we're still close to 80%. Social determinants is up there above 90%, and teen depression went down a little bit. It looks like it was a steep fall, but it's really still close to 80, which is great. Are there any questions about any of the data? And I've been going over data during coaching calls as well. Let's see, forgot to mention in the Toledo area, not having issues with referrals. And so Dr. Call had put in the chat that, and she had told us this during our coaching call, that she's having issues with some dental referrals. I know some other practices are having issues with referrals for social determinants and some other things, and not taking Medicaid. And I know Dr. Duffy is about to give developmental screening talk, and I'm not sure if that's something else that you can touch on too. Dr. Duffy is referrals for oral health or referrals in general, and how to help practices with that. But I can go ahead and pass it over to Dr. Duffy and he can get started.
Okay, thanks, Alex. And
Yeah.
I'll make a couple of comments about these comments from the practices. One is that huddles are great. I think huddles at the beginning of the day, in particular practices that are caring for children with medical complexity or a large majority of children with special needs. In some ways, huddles in the morning can be essential in a team practice that allows for the appropriate amount of time, the appropriate amount of information, the right information at the right time, in the right amount of anticipatory guidance. So that, in particular, children, it's most obvious when children are coming in on gurneys or in wheelchairs, but it's also, if you anticipate that this is a problem, a recheck for a developmental problem or a recheck for a behavioral problem, it's really important to have the whole team involved. And so a 5-minute huddle at the beginning of the day, I find really important. We did it for a long time in our practice, and I found it very important. Now, that can deteriorate into sort of a complaint session. So if it turns negative, it's important for the leadership to sort of, identify the problems and be positive about working on the problems and the problems about flow. So huddles are great. Referrals, what you're bringing up in terms of the oral health referrals, that's exactly why we're doing the things we're doing, because it's very difficult to get kids in. Once again, the children that have medical complexity, children are on medications that cause difficulties with oral health, either gingival hyperplasia or early childhood caries. Very difficult. All I can say is that's exactly why we're doing this on the pediatric practices, and I'd suggest that perhaps one of the strategies would be to continue to apply fluoride varnish every 6 months after the 3-year cutoff, and at least until a child is successfully referred to a dental home or enters school, one or the other. I've got a couple of other ideas of things to say, but let's start by moving through the slides. Next slide, please. One of the well, two comments right now. One is that of the three modules that I was asked to present, this is the one you know the most amount, and I know that because there's been a really huge increase in the percentage of practices that are doing regular developmental screening since about 2010. It was very low. It was less than a third of pediatric practices, and now it's way over 3/4. So that's really great, and I think that's one of the reasons why we're developing the routine of seeing kids and using a standardized instrument and referring them early. Exactly what you're experiencing. I think it's a success that you don't have a whole lot of referrals at 30 months. That means you're doing a good job of early detection, early intervention, and early referrals. All that said, I thought, even though you know a lot about developmental screening, I thought I'd just sort of include the learning objectives that you can see here. This kind of guide our thinking about this. And there's maybe two new ideas, maybe not. The rest of them are well understood and accepted practices. The first one, though, is to explain two reasons for the developmental screening in a medical home. You know one of them really well. The other one you may not think about, but I'm going to emphasize that. Using evidence-based screens, interpreting scores, and this is the other one that's sort of new. We discussed the 6 steps for effective developmental surveillance. The third part is connecting to community services, and I'm gonna. My slides are actually a lot of them are actually resource slides. There's not. They look packed with information, but there's not a whole lot of new information here for you. You guys you're doing this, but there may be some referral information that'd be helpful. Next slide, please. Everything that I'm going to say is on this page. If you want to go back and read the recent report on developmental surveillance and screening, it's all contained on that particular web page from the AAP. It includes the 2 clinical reports. One clinical report about developmental screening that I'll be using the graphics, and the other is specifically about children with autistic spectrum disorder. We can talk about that. I know, by the way, since I know that you know a lot about this, please just raise your hand. We can have a conversation through this half hour. I'm going to try to keep it to half an hour so we have plenty of time for a conversation. But if you'd like to talk, if you'd like to ask a question or provide a contrary report in some way, please just raise your hand and we'll do it as we talk. Bright Futures is the foundation for all this. I'll confess that I was involved in one of the rewrites, the revisions of the Bright Futures books. It's a massive undertaking. I was involved in the chapters on screening for social determinants. And it was a very, very vigorous and robust conversation among many people really throughout the world to come up with recommendations in Bright Future. So please consider having one of the books on your shelf for reference from time to time by you or by your staff. Next slide, please. So here's the sort of the new part. I think obviously one of the reasons to screen is to identify children who are at risk of developmental delay. And in my experience, I think this is supported by the literature. The severe delays are already known by 6 months. The kids with mitochondrial disorders, the kids with microcephaly and birth trauma and anoxic brain damage. Moderate delays are detected up to 3 years, but the mild delays are the ones that are most common and may not be detected in the school entry. And that's one of the reasons why we can continue to recommend the 3-year, the 4-year, and the 5-year, at least the surveillance questions or an intention to provide rigorous surveillance in those visits. The other part, though, and I've emphasized this in a number of other talks, is that there are a few things that are evidence-based in pediatrics, and vaccines certainly is one of them. Honestly, not a lot about our periodicity schedule is evidence-based. You know, I've often thought that we should have visits that are developmentally oriented. For instance, instead of having a 9-month visit, you have a sitting up and reaching for grass visit, or if you, instead of having a 12-month visit, you have a getting up and walking away and managing environmental anxiety, for instance. Those are some things that might make a lot more sense. Having a feeding visit rather than a 3-month visit, you know, but we organize our visits according to the vaccine schedule. That is evidence-based. So promotion of early childhood literacy has an evidence base. Vaccines have an evidence base, and the evidence base and promotion of attachment and relational health really is burgeoning. The Center for the Developing Child at Harvard, as well as our colleagues Andy Garner and others in Ohio, and this is an area that really can provide the most powerful mitigating factor to that limits long-term effects of early childhood adversity, to promote attachment and relational health. And the way you do that during the screening process is to celebrate the strengths. You listen carefully to the parents' concerns, and you take the approach that both screening and surveillance that both are collaborative activities with family members. It's not unilateral. It's not just checking boxes. It's a discussion. Isn't it great that you're now? The ASQ is designed to find the top limit. You should have some failures on the ASQ, or you're not using the right instrument, because the instrument is designed to provide the top limit of development. But that's not as important as identifying those activities that are involved in serve and return that promote that interaction between parents and children, has an evidence base. It's extremely important. I encourage you to think that these are the two reasons to screen. One is to identify children at risk of developmental delay, and the other is to promote attachment and relational health. By the way, there's a couple of things. One is that this talk is really limited to 0 to 3 or 0 to 5. I'm not going to go beyond that. In fact, 0 to 3 is really the limit. And in that age group, surveillance alone, the pediatrician's opinion really is misses many children. It's important to include both to reach the level that we want in terms of identification of children who are in need of intervention. And that's the final thing I'll say on this slide. That if you think back historically, the reason why surveillance or screening actually developed was to identify children that wouldn't do well in public schools. And it developed with May in France during after the French Revolution, and the idea was as public education, universal early childhood education was being implemented, they needed an idea to define and decide or detect children who might not do well in public schools. That's the whole idea. The whole idea is not to identify deficits. It's to identify children, or to alert the system that this is a child that needs a little bit more help. And that's really the sort of the attitude to take when talking with parents and collaborating with parents about early intervention. Next slide, please. This is the graphic from the clinical report, and I will sort out different areas that we will and will not talk about. The newborn care screening, the metabolic disorders, and hearing, and I'll add, the cardiac screening that's pretty much uniform now. Just doing a pulse ox in the nursery and looking for a sign on the heart disease. Those screening activities take place in the newborn period, and that's not something necessarily that happens within the primary care. I'm being interrupted here by a pileated woodpecker that's behind me at the feeding station. The health supervision visit then is threefold. Vision is extremely important, but I'm not certain that's something that everybody does. It's difficult to do without sort of secondary instruments in the preschool period. Behavioral and emotional problems are a little bit later, although I have some ideas about how we screen in the earlier age group, the 0 to 3 age group. But it's the developmental disabilities that we're talking about today, from birth to 3, and in particular intellectual and learning disabilities, autistic spectrum disorders, and motoric disorders. Again, the high risk conditions. I'll say more in a minute. Next slide, please. This is the basic schedule. The surveillance occurs at every visit. The comprehensive developmental screen with a evidence-based instrument at 9, 18, and 30 months. The autism spectrum screen at 18 months, along with the comprehensive screen. The special attention to 4 and 5 year visits, as I just mentioned, for school readiness. And I want to make sure that this schedule is considered a minimum. Anytime a concern development develops, add another comprehensive screen. You have an early return and another comprehensive screen. I don't know which practice was mentioning the difficulty with the 30-month screen. My suggestion there, as a matter of fact, would be to do the ASQ SE, the social and emotional screen. I did that for a long time, and I think it's very helpful. Once again, it's a technique to open up a conversation with parents about the temperament styles and the behavioral styles and the match between the parental styles and the response of the child. So that's my suggestion. I prefer using the ASQ SE at least once, and it can be slipped in there at 30 months, or it could be 36 months. Next slide, please. So here are the 6 steps to surveillance, and remember the behavioral, the toxic stress, or the trauma surveillance question. Does anything sad, bad, or scary happen to you or your family since last time we talked? I think that's a good one. That's a good surveillance question to use at the outset of this conversation. But then, listening to the parents' concerns is extremely important. Parents, we don't know really what their information is. The internet is so full of concerns, and the parental anxiety is. Well, I think we need to be aware that we're not just treating the child. We have a primary obligation to the child, of course, but we have a secondary obligation to care for the parent, because we care for the child through the parent. So listening to the child's concerns and helping the child and listening to the parent's concerns about the child and understanding it and confirming it or clarifying it, helping the parent feel less anxious about their skills as a parent. And once again, is another way to improve attachment. Obtaining the developmental history and observation, identifying risk, strengths, and protective factors. Now, another reason to increase the frequency of the screening, of the standardized screening. Another reason is a particular concern about the history, the developmental history of children. For instance, developmental problems are much more common in families who are experiencing poverty. So if your practice has a large percentage of people who are families who are in poverty, children who may be in a less than helpful and less stimulating environment, you may want to do formalized screening more commonly. Another very particular group of children that need more frequent screening are children in foster care. We know that the children in foster care have been exposed to trauma. We know that many of them have been involved with parents who've been involved with substance abuse disorders and may have been exposed prenatally to substances. I think it's children in foster care require more often, more standardized screening more often. And as I just mentioned, the particular mental health and substance abuse concerns that you might pick up from parents would warrant more frequent screening and a more in-depth surveillance. For instance, the mothers who are depressed, for instance, or caretakers who are depressed, maternal depression. And then there's a collaboration with sharing opinions and findings. This is something to finesse, because you start out with hearing the parents' concerns, and then eventually you give your opinion. But there may be you may want to say, well, what did you think when I said that? What's your response to what I said? Do you agree or do you not agree? You don't want them to go away with a sense that you're on a different page, that you think their child is deficient in some ways, or their child has a developmental problem, is developmental delayed, when that's not the case. The idea about surveillance, of course, is really just to identify kids who are at risk and to manage the risk. I've included a couple of resources on this page. Learn the Signs Act Early is a great website from the CDC. It's directed mostly to parents. There's a providers area, but the parental advice and the handouts and things, they're very useful, particularly for parents. And there's actually a web-based tracker. There's an app that parents can download to help them understand normal development, or let's say standard developmental milestones. Next slide, please. Okay, I'm not going to go through all this. It's very easy to think about, but this is the standard algorithm, and it's important to realize that we're talking about kids. If we remember the first slide or so, that the kids that have severe problems are identified in the first 3 to 6 months. What we're really talking about is kids that don't have identified problems arriving after 6 months, 6 months to 3 years. There's age-specific visits we'll talk about, and the physical exam that follows that. If there's a motor concern, we might consider what's in the box on box 7. If there's something on the medical evaluation that's concerning, you might consider box 8 or box 9. Then there's this sort of not very well defined area that there may be a concern on surveillance, but not enough to make a referral right then or to further evaluate. That's when you identify the concern in the record, and you set for an early return. You set a flag in the medical record for an early return. Down at the bottom, and I'm not going to spend a lot of time on this, but I'm going to give you a couple of resources. If there is a developmental diagnosis established, then you initiate chronic condition management. And that's the point that is extremely important to refer to and to collaborate with community resources. Next slide, please. There are different validated instruments, but I think that most of us use ages and stages. The PEDS it has a sensitivity and specificity, but it is a parent interview rather than a checklist. The ages and stages gives us 5 domains, and it's age or stage specific. The sensitivity and specificity is in the mid 80s. Both are sufficient, mid 80s, 80, 86, 80, 89. Each domain then, one usefulness of having domains is you can see a difference, for instance, in problem solving or problem solving or communication with motor development, fine and gross motor development, sociability. And you can make some assumptions, but you can also relieve your anxiety. For instance, if the only thing that's happening is that a child is delayed, but in expressive language, but certainly has good problem solving, good sociability, and good inner language, well, that can be that's something that's pretty reassuring. But if there's a problem with language delay along with problems with sociability, problems with eye contact and joint attention, and then that may be a red flag for other problems, particularly autistic spectrum disorder. That said, if there's a problem with motor development, but normal sociability and intellectual function and problem solving, then that's a very different idea, and you might need to pursue early intervention and physical therapy or occupational therapy rather than be concerned about global delay. And the Bright Futures, once again, is part of our the foundation, and that's the link to the resource kit. Next slide, please. Just to give you just a visual about the how the two interact. The ASQ for a 3-year, 18 months questionnaire is on the left, and the 18-month visit handout is on the right, and they're consistent. The handout is very useful. It's very consistent with the ASQ. Next slide, please. So this is a little bit new even to me. When I was in practice and doing the MChat, I was aware that there were problems with false positives in particular, less false negatives, but quite a few false positives. What's happened now is that, and many of you know this and know more than I do, there's a follow-up test that's called the MChat R/F. The follow-up is the F, and it drills down and eliminates the false identifications. Now, I looked at that, and the website, if you go to the MChat website, as I linked it, it's pretty involved. It's very it's a parental interview, and there are good questions there, no question. But I'm not certain how many pediatricians are going to do it. I'd be very interested in hearing from you to see whether you're doing that. But if you get a score of under 3 on the revised MChat, there's no follow-up needed. But a 3 to 7 then requires the MChat R follow-up, and then if there's a identifiable score on the follow-up, then there needs to be a refer to an educationalist or a psychologist to do the ADOS or another standardized test that can help with diagnosis. In particular, what we're talking about is kids that are approaching 36 months when the school system becomes responsible for the early intervention for kids and getting them into early Head Start and Head Start. So that's something that I could learn from you, because some of you perhaps are using that follow-up tool. I'm not familiar with it. I did look at it online. It's impressive, but I'm not certain how many people are doing it and whether or not they find it useful. Next slide, please. I mentioned the social emotional screen. Most of these, except for the ASQSE, are really for older kids. I've used the strengths and difficulties questionnaire quite a bit for older children, and it's very useful for older kids, but I don't really find it much useful. I don't find it useful for children under 4. And the preschool pediatric symptom checklist, I think, is a little bit along the lines of particularly problematic case. I'm not certain how many people are using that. I did not use that. I did use the strengths and difficulties questionnaire, but again, I found the most use of the strengths and difficulty questionnaire in the older age group, and I found it most useful not for diagnosis purposes, but for conversation purposes. I talked with parents and talked with them about the results of the strengths and difficulties, and it was a way for them to be more in tune to their children, or I would assume that's probably what I found useful, rather than coming to a diagnosis. Along the right-hand corner, your right-hand corner, I've included some social emotional screening for school age through adolescence, and I'm not going to really talk about today. Even the Vanderbilt, which is, I suspect most of you use. The primary care PTS screen is helpful, and also the screen for child anxiety related disorders. As we know, we've had a sort of a massive increase in behavioral mental health and relational emotional problems with children, really for the past 10 to 15 years, but got a lot worse. Anxiety disorders got a lot worse during the pandemic, and it might be helpful to keep the screen for child anxiety related disorders in your practice. Next slide, please. So what do you do when you get down to the bottom? What if you need referral? Well, the nice thing about Ohio is that there's one central telephone line that you can use. I didn't list the telephone lines for the 1, 2, 3, 4, 5, 6, 7, 8 regions, but if you go to that website, you can refer to Help Me Grow, you can refer to WIC, and you can refer to early intervention with one telephone call in your district. So if you're in Clark County, you call it Western, and obviously if you're in Holmes County, you call it the Eastern, and so forth. So there's one telephone call to refer to Help Me Grow. Help Me Grow is a home visiting program. It's not necessarily primarily for developmental disorders, although that's sort of the central intake. Sometimes they'll if you really are well documenting a motoric delay and need to go to early intervention, and that's where you go. But Help Me Grow also is the umbrella organization for things like the Nurse Family Partnership and the other evidence-based federally funded home visiting programs for particular populations that really are strongly. I strongly recommend it. I would like to see home visitors in the office. Some of you probably know that my practice at Rocky North Center in Springfield was the first Healthy Steps for Young Children practice, and that was based on a developmental surveillance or developmental assessment program by a home visitor that was called a developmental specialist, actually, and it came from the 0 to 3 Foundation in Washington, and that was picked up, and 0 to 3 and Healthy Steps are now one organization after the Commonwealth Fund pulled out of Healthy Steps. So in the full model, that's a home visitor that is doing developmental assessment within the natural environment of the child. They go to the home and do an adult development. So that seems to be ideal, and then to collaborate and to receive that information and work with home visitors. I think it's really the most robust help for families. Next slide, please. And I want to mention the children with medical handicaps. This used to be called BCMH. It's the Ohio's Title V program. And the reason I bring this up in particular here is that there's 3 programs in CMH: the diagnostic program, the treatment program, and the service coordination. And it's important to realize that the diagnosis program is also eligible for children that you might be considering autism. Treatment for autistic spectrum disorder is not covered by BCMH, but the diagnostic arm is. So if you're concerned about autism and the family is unable to pay, or their insurance won't pay for the evaluation, this is the central intake office. BCMH does a great job. I've been involved with BCMH for I don't know how many years now, almost 20 years, and they're really good people. Service coordination is mostly hospital based, but some of the public health facilities, the county and city health departments have BCMH service coordinators, and they also will do home visits and do evaluations. But this is a funding program. It almost functions as a secondary insurance, but as a matter of fact, it's unique in the United States. We should be very proud of our Title V program. It's paid for partly with general revenue funds and with local funding, but it's a remarkable program. And I encourage you to support it. Next slide, please. And once you get to that bottom, or if you identify a risk at some point during the algorithm, these are some ideas that I've had over the years about relational care coordination. Care coordination, I've used the term case management for the linking services that go on within the community to stay to a food bank or a housing support. Care coordination is something that goes on in the pediatric practice, and it means not only linking to community resources, but facilitating the visits, like I was talking about before, in terms of doing huddles and preparing for visits, getting the information together that's necessary, and making sure there's enough time for clinicians to work with families, but also developing a care plan to hear the families, the concerns and the goals and the wishes and the values of each family, to develop a care plan, and then track and collate records. These are care coordinating concerns that aren't really case management, so I use that term. And once again I add the term relational to make sure that there's a warm welcome and a warm handoff, and to manage the communication, and that linking service at the end is extremely important for children and families. Next slide, please. Here's no, one back. Yeah, are there back? One more. Forward, there. So these are the 2 codes that are used, and you can go to that website and get the coding fact sheet. Look for the one that says assessment, screening, and testing, and you get an idea of what to do at that point. Next slide, please. Well, I might say before you go, I'll just talk it through. The first 96110 is the one to use. Basically, 96112 are tests that are administered, but also requires a report generated by the physician. So it's very uncommon that you do a 96112. But if you were going to do the ADOS, for instance, the specific test for the diagnostic test for autism, then you would use 96112, and it would require a report, and it's based on that. 96112 is the first hour, and if you want another 30 minutes, then you'd use 96113. Next slide, please. And this is the last. This is sort of a workflow summary. That's pretty small on the right, but the CDC has a screening flows chart, which is very similar to the one that is but less complicated than the one in the pediatric clinical report. But just as a reminder, surveillance at each visit, screening using a standardized instrument, followed by an evaluation of physical exam, and then linking to services, early returns for uncertain findings. But if there are findings, then you link to community services, and you develop a chronic condition treatment plan. And that, I believe, is the end of my presentation. Yes, good. So I see that there's quite a bit going on in the chat, so maybe we can have a few minutes for discussion.
Yeah, Dr. Duffy, there was a question that asked, at what age do children age out of BCMH, and is there an adult equivalent?
There's no adult equivalent, but the BCMH has been extended to 25. Although for specific diagnoses, and I noticed that Anna, I think that Anna Starr was on, so maybe we could hear from somebody from ODH. But I believe that that, for instance, cystic fibrosis coverage is well covered, at least until 25, and maybe further. But that's consistent with the ACA changes in coverage for parental insurance, and it was extended to 25.
Right. And then Anna had put in information about safety net dental clinics, because I know a lot of people have been asking about referrals to the dental clinics for their patients. So that's great. Let's see. And then Dr. Comer had made a comment about the MCHAT follow-up, and she said it wasn't too cumbersome.
Good. I was impressed by the questions. That they seem one of the sort of the quick and easy tests in the age group is for concern is if you if you have something on the wall that you can point to. Children that are on the spectrum often won't be able to, if you point to a picture on the wall, they won't look at the picture, they'll look at your finger. It's kind of an easy but concerning idea that they just don't get that joint attention. They don't get an idea of that you're joining that attention to something that's a third party. They look at your finger, and that to me is consistent with that idea that if you remember, I'm rolling on here a little bit, but in 1945 was the first really of the strong paper, the evidence in the literature by Leo Kanner. And his paper was called Disturbances in Affective Contact, Autistic Disturbances in Affective Contact. And what that means is that the children weren't contacting, they weren't in contact with the emotional state of the other person. They couldn't identify when the other person was anxious or upset or sad or angry. They didn't detect that. So it's really, we think about autism as sort of a cognitive problem, and we've gotten very biological lately, but it's often very relational. It's that the children don't understand humor. They don't attached with people. There's also kind of a space in between you and them. There's an extended space. Now those are all sort of intuitive, but it has to do with joint attention and has to do with contacting another person's affective state.
Thank you, Dr. Duffy. And then Anna from ODH also said that the CMH treatment program goes to age 23 right now, and there's an adult CF program that covers meds and an adult hemophilia insurance premium payment program. It's a lot of words, but thank you for sharing.
I knew she could. I'm ashamed that I didn't quite know that, but I think that
It's okay.
the plan is that it's going to actually be extended further. So the right now may be the operative part. I think there's a plan to extend it in each biennium along with the state budget.
Great.
We haven't had a medical advisory council meeting for quite a long time. It kind of got dropped during the pandemic, and we haven't gotten it started again. So my information may be old news.
Are there any other questions for Dr. Duffy? Thank you so much for speaking for the third time, I think, Dr. Duffy. We really appreciate it, all your expertise and knowledge. And are there any other questions? Okay. Well, there's not any other questions. This will be available in recording format. I know a few people joined a little later, so I will have a recording available for everyone. And if there are any questions that come up, please feel free to send me a message and I'll pass them along to Dr. Duffy. And we will we'll be meeting next month. So please let me know if there's any questions and we will talk soon. Thank you, Anna, for sharing all your information, and everyone for being on today. Have a great rest of the week.
Thank you.
Thank you so much.
Thank you.
Thank you.